So, hello everyone. Thank you for joining us today. We are happy to have Professor Tay Netoff here. He is from the Department of Science and Biomedical Engineering. He's a professor there, and he has been working on neural stimulation with electrical pulses to treat many diseases such as Parkinson and epilepsy and chronic pain. So we are privileged to have him here and learn more about the research and the important work that he's doing here for neurological diseases. Thank you.
Wonderful. Thank you. Thanks so much for the invitation. And it's nice to see so many friendly faces here. So do I need to turn this off? Hey, Matthew, especially you. So let me, and actually I'll be talking about some of the work that the people in this room are actually actively involved in. So that adds an extra level of pressure on me. I want to give, let's see. There we go. I have a couple disclaimers. So some of the devices that you'll be seeing we used in studies today were donated by Abbott. I've had grants from, and I'm working on getting a new grant from Medtronic. And so, but I don't think any of that affects the science that, that we'll be talking about today. So neuromodulation is using electrical stimulation. It's not limited to electrical stimulation. You can also use ultrasound and optogenetics and magnetic stimulation. But for the therapies I'll be talking about today, it's electrical stimulation. You have what's called an implantable pulse generator that generates these electrical pulses. And then those go through electrodes either into like the deep brain, the spinal cord, or the vagal nerve stimulation. And so this has been FDA approved for chronic pain for stimulation in the back, Parkinson's and epilepsy, for depression in vagal nerve and epilepsy. And one of the problems with this, or one of the advantages of this technology, is that they can have a lot of contacts. So this is a spinal cord stimulator. It has 16 contacts on it. And then you have electrical pulses. You can adjust the height of these pulses. You can adjust the pulse width, and you can adjust the frequency of these pulses. And that gives you a lot of flexibility, right, to treat somebody. But guess how many possible settings there are? If you have 16 electrodes, a range of frequencies, a range of pulse widths, a range of amplitudes. I mean, raise your hand if you think it's more than 4. About a quarter of you think it's fewer than 4. Okay, now keep your hands up. Keep your hands up if you think it's more than 4,000. Okay, how about 4 million? Okay, 4 million, maybe not. Okay, 4 billion? Okay, Matthew still has his hand up. 4 trillion? Disa has her. You guys are kind of like, plants. So, it's not really fair. But 4 quadrillion is actually the possible number of total settings. And we hand these things to doctors and like, hey, look, like there is a lot of possibilities here. You just got to find the best one. And that's like kind of a daunting task, right? If you were to go through each setting for 1 second each, it would only take you 128 million years, right? And so, that's a little longer than most physicians have or lifespans of patients to go and optimize it. And so what do we do? Like, is this really feasible? And we keep adding, I'll show you, we keep adding more features and like, we can make it even more personalized, and that's great, right? So, most physicians test 2 settings, right? They'll adjust the amplitude up to sort of titrate it in. But if it doesn't work, then they might try 1 or 2 others. But if it works okay enough, they usually lock it in. But 2 is the average number of settings a physician will use. That's unlikely to be the best setting for a patient. We do clinical trials. We usually lock it in on a particular setting. Then physicians really like that. There's the setting they use for this clinical trial. So we're not going to deviate away from that setting, right? So, we think, more parameters gives us larger personalization possibilities, but how do you personalize it? What do we do? How do we measure? And let's really, we need new tools, right? And so I'm going to tell you about work that we've been doing about optimizing neuromodulation therapies for treatment of spinal cord injury, epilepsy, and pain and depression. So I'm going to run through these, just give a very high level view of what we've been doing on the people here. And DISA is part of the spinal cord injury program. Rachel and Matthew are part of the depression. No, Matthew's more of the pain. Rachel's more of the depression. Shanti, what are you working on? You're working on all of them. Pain? You're working on the pain, right? Okay, so here's David Darrow is my colleague that I work on the a lot of this neuromodulation, especially for pain and depression and spinal cord injury. So this is the stimulator here. We implant electrodes, and Andy Lampersky and I have developed these algorithms for optimizing neuromodulation therapy. So let me show you how this works. So here is a patient that has a spinal cord injury. So she had a motorcycle accident, this crushed her spinal cord. Even if you're not a physician, you can probably look at this and say, ooh, that doesn't look good, right? And so what we're doing is taking that paddle that you saw and we slip it in between the vertebrae and up into that space, epidural space. And we put the electrodes down there, and we can, use the electrodes to adjust stimulation around. And here's an actual image of us doing some of the early phase parts of the studies. So this is the patient here on what's called a tilt table. This is Dr. Darrow here. This is Dr. Pena-Pino. This is me helping them out. And then this, does anybody know who this is? That's Mel Brooks, right? So, but this is, one of the reasons they originally did these studies was they were showing that spinal cord stimulation could actually restore blood pressure. So here we tilt the patient up, their blood pressure crashes because they lack the reflexes in their blood vessels. Many of the patients have this, not all of them. Blood goes down to your legs. This normally causes a contraction to keep the blood back up, but they don't have that contraction. Blood pressure crashes. We lower them. They feel terrible. They're like, I'm lightheaded. I feel kind of nauseated. And then we tilt them up, but we turn the stimulation on, and their blood pressure comes back quite nicely. And so that's pretty exciting. But what we were surprised by, another team had sort of noticed this before, that they were able to start moving their legs to some degree. And so here is the programmer. You can see the electrode contacts that we selected to stimulate through. We're delivering electrical stimulation at 10 milliamps, 450 microseconds, and we're going to show you 3 different stimulation frequencies. And so watch this. This is just continuous stimulation. There's no feedback to the device. The device is just delivering stimulation. And we ask the patient to move their leg. So let me get the right screen. Okay, so she say lift her leg and she can move her leg up. She's been paralyzed, motor complete, can't move her leg at all for 6 years. Now we turn on 50 hertz, much easier to move her leg. So this is really parameter sensitive. We're Americans, more is better. 100 hertz is more. Not as good a control, right? You go up to 150 hertz, barely can move it. You can see some compensatory movements on our other leg. A lot of that's trying to actually, when you go kick something, you actually stabilize the other foot. So you actually see a lot of that preparatory movement when they're trying to make those. So it's not just mistakes going on. Those are like really nice demonstrations that the nervous system is really trying to do and prepare movements. But as you can see, here is 4 different settings, 20, 50, 100, 150 hertz. And you see quite a bit of difference in how well the patient can move their leg. Now, we're not going to say like every 2 hertz is going to have a completely different result, right? So, 50 to 52 hertz is probably going to be pretty similar. So how do we go about optimizing this, right? How do we find the best patient settings? I'm going to describe our process for doing this. So we use a tool called Bayesian optimization. And Bayesian optimization, this is just example of sort of a theoretical example. So on the x-axis here is a parameter. So let's just say we're adjusting frequency. So like we have a low frequency here, the 20 hertz up to 150 hertz. And on this y-axis, some measurement of like how good movement is, right? So, and then we've started by testing two. We did our 20 hertz, we did 150 hertz, and we're gonna fit a curve between those. So that curve should go through the 2 points we've actually measured, right? And then we use a function, it's actually called a functional, called the Gaussian process regression, that allows us to infer what we think, how much movement they would have at all these other settings. And one of the nice things about this functional is it tells you how much, how confident you are in it. So these are our confidence bounds, right? So around the settings that we've actually tested, we're quite confident. Around settings that we haven't tested, we're not very confident. And then the algorithm, you generate what's called an acquisition function. An acquisition function tells you how much knowledge you gain by sampling a new setting, right? And one example of an acquisition function is called the upper confidence bound. So here you can see our confidence bounds. Here's the edge of the upper confidence bound. And the greedy algorithm, you just select the best of that upper confidence bound. And so that's this point right here. You go sample that. Notice it's next to a setting that we already know worked pretty well. We actually test that, measure it. It reduces our bounds on that, right? And now we can look to see where is our next upper confidence bound. This is probably the place where we're most unconfident in exactly what's going to happen. That might also be a good setting, right? And so it will go and maybe test that, or maybe the upper confidence bound. I can't, at this angle, I can't quite tell, but it looks like this is where it's going to sample next. And what it does, this algorithm does an excellent job of balancing exploitation, so sampling around settings that we know work quite well, and exploration to make sure there aren't places out here that are actually really good that we never actually tested the parameter space. So we really want to fill out the parameter space. You could do a brute force, just sort of sample as many points as you can in here randomly, or you could just put them evenly throughout there. But this is a smart algorithm that takes all of our measurements and uses it to guide us for our next setting selection. The next question really became, what do we measure from the patients, right? So, okay, I don't have a background in spinal cord injury. I don't really know much about movement. And so I was like, well, I'm not sure what I'm going to measure from these patients. And so well, we could put accelerometers on their legs and measure the amount of movement. We could put EMG electrodes and measure the amount of muscle activity. But, a lot of times when you do these electrical stimulation, you get these strange buzzing feelings. You get sometimes you get twitches that you're not expecting. And so how do we measure those, right? And then that list started getting longer and longer and longer of things that I don't know exactly what I'm going to measure. And so we started looking at other approaches, and one came out of the psych field, which is called a probit, where you give two examples to somebody and you say, okay, test sample A, test sample B, and tell us which one you like better, right? And the beauty of this is that we don't have to ask them to define exactly what they like better or worse about a setting. And it is relatively easy for a person to say what they like better between an A-B comparison. So we pulled this. So, you probably use something like this, right? In an optometrist, A, B, A, B. If I gave you 5 examples and asked you to pick the best one, it would be hard. But if you go through them, A, B, A, B, B, C, B, C, B, C, right? It's a lot easier. So, okay. So let me show you an example of an experiment. So here we have a bunch of frequencies that we've tested. And the way we've done this is we've given the patient setting 1, they do it for a day, then setting 2, they do that one for a day. And then we ask them at the end of setting of day 2, which one did you like better, today's setting or yesterday's setting? And then day 3, they get a new setting. And then we say, okay, which one did you like better, today's setting or yesterday's setting, right? So there's always an A-B comparison. And so here you can see setting 30, and then was compared to 50, and then 30 to 300, because that was the day that was common between those two, right? The setting on that day that was common. And if you go through here, there should be sort of a setting that's repeated. And then we ask them which they like better. And so they like setting 30 over 50, 30 over 300, 200 over 300. And so we get data like this. And now you've got to actually convert it into a value, right? So we have all these comparisons. And so that's where the probit comes in. It's actually sort of a mathematical model where you assign a value to a setting, and then you look to all the settings, and then you look to see how well it predicts these wins and losses. And so if you take this table and convert it into wins and loss into a value map, you should see that settings that are high on this, if you compare it to a setting that is low on this, you'll see that this setting won over this one. And it's the mathematical model that predicts this outcome the best, right? So this is just a nice mathematical tool that will assign a value that tries to best describe this win-loss table. So once you have that value to the settings, then we can fit this Gaussian process regression to this. And so you get that mean, you get those standard deviations on it, and we can start using, after a month of settings and comparisons, then we can use that to suggest new settings for the patient. So we get graphs like that. So everything I've shown you so far, we've been doing these models in one dimension, just saying like frequency. But there are, multiple dimensions with these stimulators. So there's frequency, pulse width, amplitude, and electrode. So with the electrode, we go through and adjust stimulation settings. Disa and I do this, adjust the statement and look to see how much they can move their right leg and their left leg, and they can see what sort of muscles they can move. And so we sort of move the stimulation around to sort of balance between left and right, and muscles that sort of pull up versus extend. And so that's fairly straightforward. And then the amplitude, the patient gets to adjust because with this a device. So they have a programmer that's on their phone that allows them to adjust settings and switch between these settings. And the patient, if you change positions, your spinal cord actually moves around in your spinal column. So those electrodes are sitting there, and sometimes if you're leaning forward, it moves forward, and then your spinal cord moves away from the electrodes. So you have to turn up the stimulation. And if you're laying down, suddenly it's like, oh God, and it's just too much, right? So they turn it down. So we leave that as a parameter that they can adjust. So the only two parameters we really play with are the frequency and pulse width. So here is the pulse frequency on this axis, pulse width on this axis. The pluses are all the settings that we've actually tested with that particular patient. These are examples of different patients, and the color represents how much they like that setting. So these are settings that win a lot. These are settings that lose a lot, that are in dark blue. And then the algorithm, using the Bayesian optimization, suggests new settings for testing. So some of these are around settings that we know they like. Some of them are filling in holes with parameter space we know we haven't tested. And so you can sort of see what that looks like from these patients. But one thing I want you to look at and notice is like how different each one of these maps looks for each of these patients, right? There isn't a setting that just works for everybody, right? And that's part of the problem, because spinal cord injury is very heterogeneous, right? Where your injury is, where your electrodes are, what nervous system impairments you have are very different, and what things are actually being restored by those stimulations is going to be different. So we get different outcomes for every patient. We get different values for every patient, right? Because of what's being restored and what's not being restored. And also I want to point out there are more than two settings, right, that we're doing here. And like one great thing to point out is that in these patients, we've never had any problems with the stimulation setting. We've gone through lots of stimulation settings, never really had an adverse event from a stimulation setting caused by the spinal cord stimulator. And so it's been very safe to adjust these parameters, especially in spinal cord injury. So we've just been mapping as much as we can, right? And one question is like, well, how valid are these maps? I'll try to show you how we validate them. But part of the question is like, if you give a patient a single setting, and then you say, okay, well, I'm going to give you 5 more settings and have you test those. even if this map doesn't contribute anything important, the fact that you tested 4 more settings, there's a good chance one of those settings will be better than your first setting, right? And that may be all we're doing. I hope we're doing more than that, but at least it's empowering the physicians and the patients, and especially the patients, to feel they're participating by doing this parameter exploration. So here's an example. This is a patient, the day he went home with the stimulator on. We turned on, adjusted his simulation, did all that stuff with the left and right legs and got everything going. They were like programmed him in, and then we were like, okay, you can go home. And his wife said, wait, like, can't we see it work? And we're like, oh, yeah, if you want to see it work. So like she came up to him, he was sitting in the chair, and she said, oh, honey, kick. And he kicked. And she just like broke down crying, right? It was just amazing, right? So they went home, and this is actually just the next day is just a reconstruction of that sort of story. This is a patient who she was paralyzed for 6 years. By the end, this is about 6 months into it. By the end, she was able to do 30-pound leg presses, right? And that, but we asked her, what's the most important thing to you about this therapy, right? So a lot of the patients, when they first start moving their legs, are like, well, that's pretty cool, right? But one thing is we are restoring signals going down from the brain. We are not restoring signals going up from the spinal cord. And if I put in a lidocaine block into your nerve and you tried to walk, you would not be able to walk without sensation, right? So we tell them they'll never be able to walk unassisted, right, with this therapy. And they shouldn't have any expectations of that. But what she said was the most important thing to her was that in a room like this is kind of cold, and she never realized how uncomfortable she felt because of her temperature dysregulation, right? And the fact that the spinal cord stimulation actually helped her regulation of her body temperature, so she could feel comfortable in much larger range of temperatures. She didn't realize how much that impacted her life. She also said, I cannot express to you how important it is not to poop myself in Target. She's like, it has given me a lot of benefits in bowel control, right? That was not something we expected at all, right? Bowel control, and we've seen significant, patients have to do, with spinal cord injuries, have to do what's called digital evacuation, right? So this is your digit, right? And you have to evacuate your bowels, right? And that can take an hour and a half every other day, right? I don't think that's, great quality of life, right? And we see patients that their bowel routine goes from 90 minutes every other day down to a half an hour, right? That is an hour and a half of really, I think, some of the worst job that they don't have to do anymore, right? Those are really big improvements in their quality of life. Here's a patient. This one is a patient. She's using a walker that's supporting her, but she can time her steps so she can pull along. She kept talking about wanting, to walk, and she got some of that back. But I remember the day she came into the lab, and her husband and went up to Dr. Darrow and said, you know what? She's actually had restoration of orgasm, and I'm wondering if you can turn it down because I'm kind of tired, right? So after like 7 years of having no orgasm, like that is a huge improvement in quality of life, right? Not something we ever set out to look for, right? We had to then start setting up studies to ask about sexual function, right? Interesting sexual function studies, questionnaires. And we are seeing significant improvements in sexual function in a lot of our patients. Here are the algorithms we use to test out these response surfaces, those color maps that we're seeing. We use them to predict what setting a patient will like, and we use that prediction. So you can see on this axis, it shows what's called a Breyer skill score. So it shows how confident we are in the prediction and whether we actually predicted it. At the beginning, we don't have a very good map, but over time, it gets better and better. And for some patients, these maps look pretty good. For some patients, our predictions are not very good, but, we do see, and it's hard to tell if that's because patients just don't see a lot of difference between settings, or they're inattentive and they're not really paying attention enough to really do good quality evaluations. But almost every patient, whether we have good predictions or not, are showing significant benefits. They say they're much better off with the stimulation than without. We've also done all sorts of like quality of life scores, so like scores about depression and psychological health domain, and we see in our patients significant improvements over time. Things we had never planned, right? But you improve a lot of just the physical side of things, and relationships and other quality of life improves. This was a patient. This is Dr. Darrow, and she, of course, had to catheterize her bladder to control her bladder. She, after 6 months, said, like, I noticed that I had better evacuation with my bladder. In fact, I could get, after working on it, I realized I could get really complete evacuation. And then I realized I could actually evacuate my bladder without the stimulator, right? And so she decides, she's like, I compete again like a normal person. She'd been paralyzed and catheterizing for 21 years, right? And just like, the probability of getting UTIs, right, because of catheterization, significant improvement in her quality of life. If nothing else, that was worth it for her, right? Not every patient did we see this. No, it was just one patient we saw that. This is a guy who 6 months into the study said, hey, you know what? I really think I can move my legs with the stimulator off. And we're like, okay, show us. So we, slapped on some EMG electrodes to measure the muscle activity, and said, come in with the stimulator off from the night before. So the stimulator's completely off. He has been paralyzed for 21 years, and okay, and watch, see if you can see the movement. I mean, that's pretty exciting, right? But then he does this, right? And we're like, what? Right? Like, okay, that's movement, right? Like, you don't have to be like a kinesiologist to detect that, right? We are just so excited, right? And we went back and actually started measuring muscle activity in all of our patients with the stimulator off, and asking, do we actually see muscle activation? And we actually do. In about half of our patients, we could see muscle activity when we ask them to do a movement, even with stimulator off, which kind of screws up our stats, because we were comparing how much muscle activity we were seeing with stim on versus stim off, with the assumption that stim off would show nothing, right? Did you have a question?
Yes. How long, maybe you addressed this, but my question really is ultimately, how important is the point at which the therapy begins relative to the point of injury? In some cases,
yes.
23 years.
Yes.
What happened if this therapy began immediately after the injury? Is there?
Yeah. So we patterned our study off of another study that had been done in Kentucky, and they had said they will only take people who had essentially a year or two past their initial injury, right? And they had to enroll, and they had to be there. They had to move to Kentucky and like be a part of the study full time and live there for a year, which costs about $1 million per patient, right? They had done about 15 patients when we started our study, and we were like, that's not a model that we can really reproduce, right? It's just too expensive to do that. And also, like, there's so many people who are well beyond their injury. If we can show one patient has some benefit, even if their injury is a long time out, our expectation was the spinal cord degrades if it doesn't have those signals going there. So you get this Wallerian degeneration, and it was like, well, slapping a bunch of electrodes into this degraded spinal cord is not going to get us anything. So the fact that we saw benefits in people who were long past their initial injury was quite shocking to us. We don't really know how much more benefit you get by doing it early. We're just grabbing everybody we can that can participate in the study. We just implanted our, is it 26th patient? Yeah, so but, we've done 26 patients. Every patient is so unique. But it was a revelation in the field that you could implant. Our first two women that we implanted were the first two women ever, and that were beyond 2 years out from injury. So it meant this could help a whole lot more people than people who are just in that window. If you just look at the number of electrodes, there's like 43 million possible combinations of just doing anodes, cathodes, and off on these electrodes. So, this is a problem. Actually, I'm working with DISA on this. So one of the questions is how can we optimize this therapy? Let me check on my time. It's 12:52. Let me just rip through this because I want to show you a couple other examples. But what we do is we try a whole bunch of different stimulation settings. We measure the muscle response in each one of them. And the idea is that there is some kind of mapping. So you have your electrodes in the spinal cord, then you have the muscles, the nerves projected to those muscles, and there's a map there. But we don't know what that Matthew. You're not in the back row this time. I had a hard time recognizing you.
41.
Is what? Oh, this clock says 12:52 here. So thank you for correcting that. Okay, I'm just gonna have you sit here like giving me numbers for the time. Okay, so there's a map here, right? And we don't know what that map is. And so the idea is that we will take all of these results. So we have our stimulation electrodes that we turned on that actually creates an electric field. And then what we usually think is that the nerves are actually sensitive to the second derivative of the electric fields, which is called the activation function. And so we calculate that activation function. And the idea is we have these activation function maps. So these are the 42 activation function maps. So this is spatially what those activation looks like for each one of those electrode combinations. And then there's this map that takes us from the from the activation map to the muscles. So this is the map we don't know. And then here are the actual combinations of the electrodes that we stimulated. It's 42 different patterns that we stimulated and the muscle response from the 16 different muscles. And so here is what we look at this as a sort of a linear algebra problem. And this is what we don't know. So we just sort of flip that and solve this with our standard linear algebra techniques with some kind of nonlinear function. And we can generate a map that will take us from electrode space to the muscle space. And that somehow represents. And so when we generate what the spinal cord is doing. So here's examples of what these maps that look like that activate each particular muscle. So this is our 16 muscle electrodes we have on the body, and it tells us exactly where to put the fields to activate that particular muscle. There are different nerves coming out that innervate that same muscle. So that's why you see this sometimes in multiple areas that are sensitive to it. And you can show examples of like here, how much activation we actually measured on a muscle. And that's in black here. That's our target. And then the predicted, if we actually gave it just the electrodes, how well we could predict what the muscle activation would be. We do a one leave out to do this. So we actually train it on 41 patterns of stimulation, and then we take that 42nd pattern and then we put that stimulation pattern in and we look to see what muscle activation it predicts, and then we actually see how that compares it to the actual muscle activation. And so this is something we're working on and testing, and one of the things that we would love much higher resolution of the muscles. So there's actually arrays that we're looking at getting hundreds of electrodes onto the leg so we can actually measure every single muscle. And then we can go backwards and say, okay, now that we have our muscle map, we could say we want to activate this particular set of muscles to create this exact pattern of movement. What's the optimal selection of electrodes? So this was the stimulation pattern that we used to actually activate it. We saw this muscle activation. This actually turns out what the algorithm considers the optimal stimulation pattern. Anodes, cathodes, it doesn't really care. But it's kind of the similar spatial area, and it predicts similar patterns of some of these muscles are highly activated and some are not. So, we're testing that. But this is I know this being the biosensor seminar, I'm like showing places where we really can use biosensors to really help us. Here's an example of how we did an optimization for chronic pain. So this is a patient who had a stroke in their thalamus. That ended up resulting in felt like their face was cramping constantly, and they were in an 8 out of 10 level of pain for 2 years continuously. Right? They tried all sorts of stuff, nothing was benefiting them. Dr. Darrow pointed out there was a couple brain areas that patients had been, or surgeons had seen in the past, had given some benefit to chronic pain. One was called the dorsolateral prefrontal cortex. The other is the facial motor area, or the facial sensory. It was facial motor area, was surprising. And he's like, nobody's ever actually tried to combine these two. So we put electrodes in through, we did a burr hole here. We threaded one set of electrodes. These are the same, similar to the spinal cord stimulators. They actually designed for spinal cord, but we put them on the cortex, and we threaded another one down here. It has 8 contacts on each one of them. And then we did our Bayesian optimization, because I have one hammer. And that's what we did. We mapped it out for each brain area for the motor and the dorsolateral prefrontal cortex. We found settings that she really liked. We combined the settings, and she said after combining those settings that her pain was gone for the first time in 2 years. Like she was a changed person after talking to her. She talked about what things she was planning to do in the future. And she really she talked about just what a disappointment she had been to her father, just not being able to do anything and just living in her bedroom for all this for 2 years. And she was just like, I feel like I can start living my life again. We've done several other patients now. I think we've just done our 5th. Matthew, are we on our 5th pain patient? We've done 8. Oh, yes. That was sad. So with infections, you don't want to get it into the brain. So we implanted him, tested out for a couple days afterwards, and then we were worried about an infection, so we pulled that out. So, and some of the patients, one of the patients, I think most of his pain was more psychological, and so he wasn't getting a lot of benefit. But most of these patients see significant improvements in their pain. Now I want to tell you about epilepsy study that we're doing. So this is with Robert McGovern, Bob, and we're using a device. This is the stimulator that goes down to electrodes in the brain, into the thalamus, for treatment of epilepsy. And this has been shown to be fairly effective at alleviating seizures. So they delivered 145 hertz at 90 microseconds, and they stimulate for 1 minute on and 5 minutes off. And they showed that after about 5 years, about 70% of those patients show a response. And a response means that they have a greater than 50% reduction in their epilepsy. Now, that's pretty good. That's improves quality of life. But, your life isn't transformed until you get to 0 seizures, right? And so even 1 or 2 seizures a year still, really impacts your life. And so, is 145, 90 hertz the best, right? So, of course, we got to ask, can we improve that and optimizing? And one of the cool things that this device has is that came out just a couple of years ago, and at the time we started the study, is not only can it deliver electrical stimulation, but it can record your brain activity while delivering that stimulation. And so we thought, let's use brain activity to actually help us optimize the therapy. So we came up with a real simple idea of we're going to look at a particular frequency band. Here are examples of where all the electrodes are in the thalamus and where they landed across all of our patients. These are actually seizure frequency from our patients over time. Look at these times. These are from up to, this patient is probably another couple hundred days out from this time now. But we have patients that are years out in time, in days, right? We have, in these guys that are blue, are all patients that are considered responders. Some of these are not responding yet. And I'm going to show you how we do our optimization. So here is what the electrical signal that comes from those electrodes, so from the left and right side of the brain, and we turn on different stimulation settings. So this stimulation here, you can see it shows up in sort of a fuzz on top on both sides of the brain as we're delivering stimulation. And you can see that this is called a spectrogram. So this is time here and frequency. And you can see that artifact here from the stimulation being on. And we then go and try 9 different settings. So we start off with 90 hertz, 145 microseconds, and we go up and down in frequency and up and down in pulse width, and we test all 9 settings, and then we repeat the center one again at the end. And then we measure the brain activity, and you can see this device is really, really nice in that you can actually see the brain activity while stimulating, and you can see how much this brain activity changed while this stimulation was on. And I'll show you on some other examples where it looks a lot better. But we can then download these 9, the brain response to these 9 settings, and then we developed a little app that we can, in the clinic, analyze the data, and then it makes a response surface and then makes suggestions for more settings to test. So we do about a half an hour recording of the 9 settings. We do like a 10-minute data analysis. We then use it to suggest settings that we think suppress that brain activity that we're interested in more. We test those, and then we can send the patient home with what we think is the best setting out of the 14 settings that we've tested. How do we tell whether this actually works or not? So the other cool thing that this device is, not only does it record at high frequencies in the clinic, but it actually gives you recordings at home too. And so it records the amount of brain activity it measures. You have to specify a neurofrequency band, but it will record and tell you how much activity in that brain every 10 minutes for 2 months before it fills up a buffer, and you have to go and download it. So we have across the 16 patients we have in the study, we now have probably 28 years of almost continuous recordings of their brain activity. So every 10 minutes, you can't tell what the person's thinking, right? But you can see sleep cycles. You can see it going up and down during the day. You can see changes that are happening on weeks-long cycles. You can actually see events that you can actually see when they log a seizure, and you can see change in their brain activity. In some cases, this brain activity shows a decrease in the activity up to 8 days following a seizure, right? And so we can look to see how this activity with our optimal stimulation versus our just a standard clinical setting, and if there's differences in the amount of brain activity we measure. And then we also can see how it changes with different settings. So this is one setting, we switch over to another setting, and then we switch back. We can see how much of the brain activity, and we can also count seizures. Seizures are so infrequent, it's really hard to use as your metric as an outcome. So we really need the brain activity as a metric for optimizing. But when we started this study, we were looking at this band here. We had said, hey, there is a known band here. This band we think is going to be predictive. If we can suppress that band, we think it's going to be really good for suppressing seizures. So we're going to optimize across this band. But then when we started the clinical trial, we started seeing this other band here, which we call low gamma. And here you can see this is across visits, right? So these are different. This is the beginning and end of the same visit, right? And these are different visits. And you can see how that gamma sort of is there, but when you turn on the stimulation in red, you can see how much it's suppressed by, right? And so we see a strong gamma, and it seemed to only really show up in patients that are responsive to this therapy. So this is one of the places where we're using these sensors implanted in their brain to help us guide how to optimize the therapy, and maybe even identify patients who are going to be responders to the therapy. And we're also starting to look to see, can we use the brain activity to help us predict when a patient's going to have a seizure? And we're actually getting some pretty good prediction accuracies. And we've also seen that these gamma rhythm changes over time, over visits, And across these are the responders, these are the non-responders. You'll see that there's some gamma rhythm, at least in the responders. And also we looked at, just trust me on these, I'm not going into details, but we also looked to see like that gamma rhythm changes over time, and we actually saw that it actually correlates with the amount of seizures that they have. So we think it might be a really good biomarker. Last story, because this is for Ziad's lab, who is here, many of them are here, is our depression study. So this is a patient. So this is Ziad Nahas and David Darrow. Damien Fair did the functional MRI with Robert Hermosillo. This is a depression patient that we had who had severe depression from when he's 13 years old. He had been through something like 26 different interventions. None of them really showed him any significant benefits, long-term benefits. So Damien put him in a functional MRI and maps out all these different circuits that are in the brain. So we can get these circuit diagrams identifying what parts of his brain are representing what circuits. And we know there are certain circuits in the brain that are involved in depression. And so the idea is we would slap down some electrodes down over areas that we know it's this dorsolateral prefrontal cortex that are involved in these circuits. But not only could we just know where the anatomical target is, because we use the functional MRI, we could see specifically what circuits and which electrodes we have to activate. And so I'm worried that we're not going to be able to hear this. Let me see if I can. I think I have to share my audio, right? I forgot to do this. Share computer sound. Okay, so let's see if you can hear this. Nope, you can't hear it. You can hear a little bit.
Just sensor waves, like a wash.
You can read the captions.
Look at that smile.
This is the first time we'd seen him smile.
Emotional, huh?
It's not coming out of here, though. Yeah.
What is making you cry right now? It feels good.
So this was a pair of electrodes we had selected over a very specific target. Rachel, you still look almost about to cry. I think you were on Zoom watching this, weren't you? Yeah, when it actually happened. This, of course, is my computer. Very important cameo there. But like it was really amazing, right? Like you could really just see his emotions change immediately, right? When we turned on the stimulation. And when he talks about it, he talks about like we asked him to describe it, and he was like, it felt like I had been a kid lost in a grocery store for all of my life, and I had come to the conclusion that I was going to be a grocery store boy for the rest of my life. And then my parents came around that corner of the aisle, right, and I saw them. That feeling, he said, is what it felt like in that moment there. And he said, even if I never felt that again, all the neurosurgery and the electrodes that we did and the 4 days of testing that we put him through was worth it, even if he never felt like that again, just have felt it once. But we, did not leave it at that. So we programmed him with stimulation settings and tested them out, made our response maps. We started, honing in on this setting. Very interestingly, if you just increase the pulse width a little bit, he really went from his favorite setting to one setting that he said was really terrible. We were really under the impression that pulse width was going to have no effect. So this was really quite surprising. This is one of the nice things about actually asking patients, right? Because we're not bringing in our priors to the system. And so, we were honing in the last month to test these settings and, do our due diligence, do our one exploratory setting, right? So we had kind of an exploratory setting. And then we tested that, and he was like, oh, I love this setting, right? And so that's the setting we sent him home on. And here you can see his depression scores. These are his depression scores at the start, normalized to his, so 100%. we were optimizing. It gave him some benefit, but we're testing settings that sometimes are good and sometimes they're bad. So it's sort of going around, and then we lock him in on his favorite settings, and his depression scores have really just come down over time. And he's really now in full remission. He's almost a year. How, Rachel, how far out is he now? 33 months? And like he is a different person. Yeah. It's just, it is astonishing to see, right? Um, so, in summary, I want to sort of close this up. We have a lot of electrode options, right? These are getting more and more complicated. Everyone's like, more electrodes is going to be better. But, if you have 42 million possible combinations, is, 5 billion combinations better, right? Right? Like, I don't know, right? Maybe, right? But we need some way to actually guide people through this. We need sensors and feedback. We know that we have closed loop controls. We are using this sort of, but we got to think about this in the order of, like, we have our implantable pulse generator that's generating stimulation, goes into our nervous system. We have behavior as outcomes, right? We can also measure biosensors and all sorts of biological information. And what kind of information do we need, and how will we use it? Well, we can use it to monitor activity. We want to know, there's a lot of externalities that go on, like patients' drugs, drug loads and their drug regimes can change. One of our problems, of course, with patients is they have a lot of life events going on, like they're going through divorces or going through legal things. They're extremely stressful, right? And one of the things that they talk about is that what really shows, what's surprising to them is how much less those events impact them with the therapies, right? That they're more resilient. We don't have great measures of those, right? We would love to be able to start seeing when patients are getting worse and proactively, start working on their therapy before they really get to a crisis and wait for them to come in, right? These are where biosensors can really help us a lot. There is a lot of interest, especially in our spinal cord injury, of measuring blood pressure, but that's a really good measure of a lot of things. There aren't good blood pressure measures out there that aren't, using a blood pressure cuff and extremely. My wife was in a study, it blew up every half an hour to measure a blood pressure for 24 hours. It was miserable, right? Measuring blood levels of drugs or other biomarkers like cortisol and different metabolites. We really think, as you are improving somebody's quality of life, it's going to be relatively easy to show things like metabolites and cortisol are going to improve, right? If we could show that, that's great. Do we have to have them spit in the tube all the time? I don't know. That might be what is a good solution, but and then as we start producing multimodal sensing, so like if we have accelerometers, and we have galvanometry, and we have all sorts of biological sensors, then we can really start synthesizing these all into one metric, right? Which will provide us much more richness in understanding what's going on, and also contextualize a lot of the data, so that we can really make much more robust algorithms and that are much more sensitive as well. So finally, I'd like to thank all of my colleagues. I'm sorry, I put people that directly in my lab. And so these are my grad students and postdocs that work on this, and then David Darrow, especially Andy Lampersky and Bob McGovern, and of course my funding. Where's my funding slide? And I have funding from NIH, and I added that. Okay, so thank you so much. And we have time for questions. I think it's reserved till 1:30, so
It was a quite impressive talk, and I really
Thank you.
love the last part for the biosensors. It's
try to tighten it a little bit,
It
make a
was
little
really
effort,
like
so.
impressive. Any questions from the room?
Were you guys using like electrode mapping to the MEG data?
Yeah.
And you guys, one of the things you said was like, these people are never gonna walk again.
Yes.
And you're measuring
Yeah.
muscle
Yeah.
response.
Yeah.
And one of the best benefit was like, bladder control stuff. So have you
Yeah.
guys looked into measuring like pelvic floor or some of the core muscles that are more involved with some
Yeah.
of the more kind of organ control type things?
I think it's a great point, right? So, one, I felt like when we were proposing that study, I'm like, motor control is not our ultimate destination, right? So why are we proposing this? But I also think if we can show this kind of mapping, we can use it for any of these other things, like, pelvic floor, which I think is probably even more important, right? And bowel control and things like that. And so I think it was more the proof in to show proof of principle, right? To show that we can do this because we have an easy readout that people understand. They can sort of link it to exactly what why it might be important. Say, like, if you're training them and ask them to do a particular task, simulating in a pattern that might facilitate that task, not just do it for them, can really help those pathways. But I think you're absolutely right. Like, other maps are probably much, much more important.
Wonderful lecture.
Thank you. Thank you.
You mentioned stimulation is more essential to distal, but not distal central.
Yeah.
Is there any hope of creating that loop and getting full?
Yeah, that's a great question. So let me first step back and explain why we think we're restoring it going down. So our current, and DISA is really one that's really helping develop this hypothesis. So and correct me if I'm wrong. So our thought is, you actually have a lot of inhibition coming from your brain, coming down into the spinal cord. And when you have this injury, what happens is you lose a lot of those inhibitory pathways. Your spinal cord is used to working in this sort of balance of excitation and inhibition. And when you remove that inhibition, now you have overexcitation. So the stimulation actually seems to be causing signals that are going back down the spinal cord and activating the local inhibitory circuits to bring it back into balance so that it can listen to those existing signals. So we're not actually restoring the signals, we're restoring the ability of the spinal cord to respond to those signals and put it back in this activation range. So do we have the same kind of problem going up? It's probably not, right? Could you use, what the standard tools people have been, or approaches people have been using towards spinal cord injury is like, well, let's put something up in the brain, measure what we think they're trying to do, and then stimulate in the spinal cord. But the number of axons, even if it's 10% of your spinal cord that are connecting your brain to your spinal cord, is very large compared to the number of wires you could ever generate, right? And also, they're already in the perfect spots in your brain and going to the perfect spots in your spinal cord to do that. So, like, we already have like almost a perfect setup, right? Even if it's not like ideal, like a normotypic, but it has a lot of benefits there. Going back up, maybe we can do things where we're measuring things and deliver stimulation up into the brain and do that and restore it, that path in that more standard approach of like, let's bridge it. But we're not a part of that. And we support that idea. We might get involved in that, but that's not what we're doing.
One more
Oh.
question. Is there neurogenesis? I mean, in the case of the patient,
Yeah.
stimulation was off, and
Yeah.
Are we creating new neural pathways?
Yeah, so there's animal studies, particularly like colleagues of ours down at Mayo, that are like doing spinal cord injury models in pigs and looking at neurogenesis. And yes, I think like the electrical stimulation itself can generate neurogenesis. This is something we have a hard time with reviewers that can't disambiguate between we're actually doing this in humans versus in animals, right? And so they kind of want to know questions like that. And I totally agree. I want to know those, but we can't biopsy these patients. We can't, sack them and, do, and look for neurogenesis, right? So, these are questions, unfortunately, because we're doing it in humans, we can't directly look at, but there are really great animal studies that are going on answering those kinds of questions. And I think there's a lot of parallel showing us that probably what's going on is something like neurogenesis, as well as just really, I also think that a lot of times the pathways are so complicated that it's really hard to get your brain to control the exact pathway to get the movement. And the moment you add a little bit of help, they start recognizing those pathways. So there's might be some refinements and things like that, but just learning the pathways to control it, once you get any feedback, helps a lot. So I don't know where it is on that spectrum, but I agree. I think it's probably a part of it. Yeah.
I'm just curious, like, how viable the treatment this might be for pediatric patients, like hormones and you've got growth plates and all of those things.
Yeah.
Is that ever a potential, maybe? Pediatric?
Yeah, I mean, we're doing one step at a time. I think the next obvious one is we're doing paraplegics, but people are like, tetraplegics are much more affected. The nice thing about kids is they're still developing, they're so plastic that they have a lot of resiliency. Part of the problem is, of course, if you put in electrodes into a patient whose spinal cord is and spinal column is changing over time, you don't know like how you're going to track that, but I see no reason why it couldn't be used. Yeah.
I also have like a strength kind of question.
Yeah.
Do you see differences between people that are left and right hand dominant for different things? Do you take into consideration like dominance of
Yeah, I mean, we keep track of that. I think we added it in some of our study, in some of the linear models that we put together. I don't think that's shown anything because we have probably so few left-handed people in it that we just don't have enough power to detect something like that. But yeah, I mean, that is a good question.
I'm left-handed, so I'm always
Ah,
curious about these
yeah,
kinds of
yeah.
things, 'cause
Yeah.
I'm ineligible for like MRI studies, like,
Oh, really?
you know,
Okay. Some.
so I'm
Yeah.
curious.
Yeah. DC, you have any thoughts about left-handed versus right-handed?
I think it's more so dependent on injury level and like the injury pattern, less so on any top-down information. I think it's more so,
Yeah.
I mean, it could be, but it would be
Yeah,
like
yeah.
higher level than like all the really gross stuff that we're looking at. Yeah. Okay.
Any questions from the Zoom land? If there is any, just unmute yourselves.
I mean, I know all these people, so
Oh, okay.
that are here, so they can ask me anytime. There's a couple I don't know. Okay.
Thank you, everyone.
Thank you so much.
Thank you. It was
It was a
great.
pleasure.